very, very pleased to have you all with us for an extremely important panel, I think, about access to justice and health. I'm Lynne Haultain. I'm the Executive Director of the Victoria Law Foundation, and as you're probably aware, the Australian contingent is apparent at this conference and is certainly well represented on this panel as well. So we'll get to that in a little later. I just wanted to give you a sense of how we're going to run this show. I will introduce you to the speakers as they speak, because I think for the online viewership, it's important that they have some indication of who they're listening to. And then I hope very much that we'll have time at the end for a very robust Q&A about the issues that you'll hear about this morning. So we are keeping very tight to time, and yesterday was an impressive performance. So I think we need to maintain that commitment to brevity. And for all the conversations that I've had, people have been really pleased with the sort of concision that the time frame has required of us. So I think it's worked out extremely well. So tight time, panelists, 10 minutes each, and I will literally, hook you off if we go over in the interests of equity and open discussion. I will quickly let you know that our speakers this morning, and I'm trying to get the order correct, so maybe I won't get the order correct in this instance, but we have with us, well, Liz Curry, Michele Leering, Patricia Vagg, Amy Slotek, and thank you, Jenny Stone, sorry, two of whom I've just met this morning. And we will hear quite a bit this morning about health justice partnerships and the critical contribution they're making to access to justice. And also a really interesting lens that Patricia is putting over the access to health or legal services through a health provision lens at the end. But I'm going to kick us off this morning talking about data. Some of you may have encountered the Public Understanding of Law Survey, which is a population sample survey that the Victoria Law Foundation has recently completed. So I thought I would take a look at the health implications, if you like, or the data that reflects on the experience of legal problems and health, that intersectionality in this presentation. So I think, how do we get my slides up? There we go. So legal problems are bad for your health. Surprise, surprise. We all, didn't know this was coming. So the Pulse survey is, by way of a little bit of background, population sample, probability sample of 6,008. The 8 are very important. Across Victoria, we conducted it in 22 and 23. We had to put it on ice for a bit because we were hoping to be in the field in 2021, end of 2020, and needless to say, the world turned it against us, and that didn't happen. But it's a really, really significant and extremely rich data set that we will be mining now for an extended period of time. Classic iceberg, of course, the legal understandings we have about how people come to law are generally understood through institutional records and data sets, and not unless you ask the people what they're up to, do you find out what's happening under the waterline. So just in terms of context, the prevalence overall of the Pulse survey is there for you to see. And in the second set of dot points there, the demographics that we are looking at for this particular presentation around long-term health conditions or disability and for mental distress. And as you'll see, the numbers there are not insignificant. 23% of our sample self-declared as having a long-term health condition or disability, and 35%, or over 2,000, as having a level of mental distress, which we measured using the Kessler scale, which I'm happy to explore later if people are unfamiliar with that, but it's a very widely accepted short scale, which particularly goes to anxiety and depression type disorders, and clearly to more severe ones at the severe end of the scale. So that's the framework that we're looking at. But you'll see quickly in the overall prevalence, predictably goods and services were the dominant problem type. going down to business or investment or property problems at the bottom. So the questions that I was looking to ask in this presentation are, what does your status as somebody with that those characteristics around mental or physical health conditions do to your problem experience, and what or whether or not legal problems lead to poor health. And luckily, Pulse has given us some very useful insights on both those questions. What we did do, and I have to credit our data analyst, Zhigang Wei, who did a masterful job in creating an indicator of 6 categories for the purposes of this presentation, which looks at respondents by both disability and mental distress, and you'll see more of that in just a moment. So what we see here is that that 6 category indicator by the numbers, so just of the overall sample. And you'll see in the left-hand column, those are people with no mental distress and no physical disability. And then the next 2 are around whether or not you have disability and or mental distress, if that makes sense. I hope it's probably not big enough to see. But it's a predictably sawtooth pattern, if you like, with people demonstrating levels of mental distress in the first 3 and disability and both conditions in the last bar chart there. When you look at that, it's going down. So the numbers in the population with both those conditions are very small. However, if you look at the prevalence of any problem that we looked at through the Pulse survey, the sawtooth shape reverses, and very, very plainly. So people in the left-hand column are those with any problem who are without any disability or mental distress. People in the far right column have both. So what we see here is a really clear indication that mental distress and disability have a very significant bearing on your experience of any legal problems. So this is, I'm not expecting anyone to really grasp this, but it is, I think, a useful table, which I'm happy to share around the experience across those cohorts against the overall sample. So I did have notes here around the actual data that's presented here. There we go. So except for goods and services, which is pretty universal across the board, and that's the top line there, mental distress indicates really poorly across all categories, and even more so when in combination with disability. So for example, you can't really see it, but chronic illness or disability by itself shows some elevation. But if you have mental distress as well, it's consistently higher. So for example, in the category on housing issues, 1 in 4 people with severe mental distress had housing problems, compared with 14.9% who have long-term illness and 10% in the overall sample. And that pattern is repeated across every single one of those problem types, where mental distress by itself and in combination with disability has a really profound impact on people's experience of problems. This one I just throw up because the colors are really good and really indicative, I think. This is mental distress alone, but I think indicates very, very plainly what I'm talking about there, that if you have moderate and then even worse severe mental distress, you are in much, much higher category of likelihood in terms of having significant legal problems in those areas of investigation that we looked at. One of the other things that we did, which is quite tricky to do for those of you who are familiar with these methodologies, is try and get a gauge on duration of problem types. And this is duration of problems by those six categories of mental distress and physical illness or disability. So what we see here is that around 40% of all problems concluded within 6 months, and this is across the whole sample, so not represented on this slide, and just over 55% over the year, and just under 30% going on for 5 years or more. So once again, that top red line is mental distress, and you've got a much higher percentage. We're sitting at what, about just under 60% there of people with high levels of mental distress having problems that are lasting longer than 5 years. So indicative of very stressful and impactful experience of legal problems. I'm really skating through this, so please come and talk to me later if you'd like any more detail. We also looked at people's capability, and this is one of the breakthrough dimensions in the Pulse survey. We measured capability at a pretty extensive level for the first time in a population sample. And what we found is that as we understand capability, which is defined by us as required for an individual to have an effective opportunity to make a decision about whether or how to make use of the justice system. So it's a pretty broad definition. And we measured that in a number of ways. We asked people about their legal skills, what knowledge they had, how they understood the relevance of law to their problem, their legal literacy and their digital literacy. We asked them about their confidence in law and legal process, and we asked them about their attitudes to law, so their perceptions of lawyers and systems and trust and the like. I'm going to focus in today in this slide in particular around just the practical legal literacy dimension, because we thought of all the measures, this was probably the most relevant to discuss within this cohort. And that's the ability to get, to understand, and to apply information and services in order to deal with everyday legal problems. We used health surveys as the basis for our construction of the questions around legal literacy, because they're much more useful. And we did not use legal scenarios particularly. We used adjacent things like dealing with banks or local government and the like in order to give people sort of examples and opportunities to talk about experiences that they may well have had in order to sort of parallel with managing legal systems. So once again, you see the same pattern where experience of physical disability and or mental distress has a really profound impact around practical legal literacy, at least in terms of people dealing with legal problems and their capability to do so. So I think, I'm going to blithely now announce that we have proven or shown in the data that mental distress and physical health and disability has a very profound impact on your experience of legal problems. Once again, the data is all there and I'm happy to take anyone through it. So what we've seen is high prevalence. I didn't show the data around clusters, but we also have very significant evidence around higher numbers of problems for these particular cohorts and lower capability to resolve and respond to them. And yeah, we did do some multivariate analysis in order to isolate those findings. So looking at question 2, i.e., do legal problems lead you to poor health? So we asked people what happened to them as they experienced their legal problems. And as you can see, stress is off the charts. This is the whole sample. And loss of confidence and damage to family relationships, ill health and the like are also very apparent there. So what we see there is, in addition to the 20% who say that ill health or injury is a direct result of their legal problem, I think the measures around stress and loss of confidence have a really profound impact. They can cause, as we are, I think, well aware, significant levels of stress, significant levels of mental impairment as a consequence. So the cascading effects of these outcomes for people are really profound, and I think demonstrate the interrelationship between stressful experience of law and your health. So we haven't done a whole, or I haven't yet done a whole lot of unpacking around the implications of and the interrelationship between stress and problem experience. But I think on the face of it, it's pretty clear that we can say that there are serious health consequences for people who have high levels of high problem experience, and even kind of any problem experience. Just as a complete aside, the stuff around loss of employment and having to move house were also pretty extraordinary, with 15 and 13% respectively. Those issues, as you can imagine, would also tip into stress and loss of confidence and all the other factors that go to exacerbating people's mental health. We did have a quick look at COVID because we came immediately after it, and the impact of COVID on people's problem experience, whether or not it was caused or their legal problems were caused by or exacerbated by COVID. I won't go into that. As you can see, it's a very dense slide and it would take a bit of time. But just rest assured, if you're interested in that consequence, then we've got some data. But what I really did want to wrap with are some thoughts that we've had around the implications. This was my effort to do a puzzle. So this is my indication of how difficult it is to get to law. But what I think is very clear here is that the intersect between health and legal problem experience is extremely strong. And consequently, we need to recognize that when it comes to both our policy development and our service delivery. And we will hear a great deal more about health justice partnerships in just a moment. And that intersect, I think, has been well recognized for a long time. But we also started thinking about what else we could do. And Hugh McDonald, our research director and my fine colleague, suggested, why don't we actually add it to the list of GP social prescriptions? I don't know if this is a thing in Canada. Yes, good. Where people are instructed by their health practitioner to go in search of legal assistance, because that will help them address some of the stress issues that are exacerbating their poor experience of life. So that I thought was a neat contribution. But I suppose the one for me that came out of this, particularly around the very, very strong data on mental distress in particular, both at moderate and severe levels, is that it may be worth considering using the K6 scale, which is very simple and relatively short, at triage stage in service provision. Because recognizing either at triage or at some point in service provision that somebody is experiencing moderate or severe mental distress will have a significant bearing on their experience of law. And I think it should have a significant bearing, therefore, on our service provision to them. I will leave it there, but I look forward very much to further discussion and hand over to our next speaker and get out of the way so there's a bit more room on this table. So Liz Curran, former Victorian / Canberran, now residing in Nottingham, in the UK, where she's Associate Professor of Clinical Legal Education and School Research, Impact Lead at the Nottingham Law School, also an Honorary Associate Professor at the College of Law at the Australian National University in Canberra, and author of a very fine book called Better Law for a Better World, which I was very pleased to be at the launch of a couple of years ago. And as you will hear, Liz has had a very long-standing commitment to integrated practice and to the evaluation of various manifestations of integrated practice. And I look forward very much to hearing about addressing powerlessness. Over to you, Liz.
Lovely. Thank you so much, Lynne. Thank you. Lovely segue too. Thank you, Lynne, for setting the context so well. I'd like to acknowledge the land we are meeting on as the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabeg and the Chipenga, the Haultain Sauni and Wendat peoples, and acknowledge that it is now home to many diverse First Nations, Inuit and Métis people. I'd also like to acknowledge that Toronto is covered by the Treaty 13 with the, Misanga of the credit. So I'd also like to acknowledge all members, any members of the First Nations people here in the room today. And I'd like to express my respect and admiration for what you're doing in the current truth and reconciliation process in this country. So my paper is addressing powerlessness, the Bangarai Bang Mayalanga, which is Wiradjuri for empowering and alleviating. It's not a direct translation. It's a little bit like, you know, in English, the French and Italian say, in French and Italian, there's like 12 adjectives to describe one. And so in Aboriginal language, often there are deeper meanings in the language. So the best translation is what the community said they wanted this project to be, around empowering and alleviating. It's a health justice partnership, which is between the Hume Riverina Community Legal Service and the Albury Wodonga Community Controlled Health Organisation. The two partners operate on a border between New South Wales and Victoria in regional rural Australia. So that is the context there. Now, I'm just hoping I can do this. Oh, well. Now, I am also going to start my presentation with something that I have learned through this process of doing the research and evaluation for this health justice partnership. And that is, I need to start with a position statement of my positionality, because I'm a white person conducting research, although I'm doing it with and alongside Aboriginal people who are co-designing and participating and in the research. So I've worked as a practitioner, a lawyer, and as a researcher and educator in access to justice for over 3 decades. Currently around the world, people who experience inequality are disproportionately least likely to gain legal support or expertise. This contrasts with repeat players in the legal system, such as governments and well-resourced companies. At the same time, many in the population, which this research tells us are likely to have multiple cascading and intersecting legal issues, are getting the least help of all. I've worked for legal aid, non-government organisations and legal assistance services, as well as being a litigation lawyer, consumer lawyer, and worked for private law firms. My research and evaluation work is around effective legal practice, what makes a difference and what has an impact on people's lives and the lives of community members. As a white person, my practice is to have Aboriginal cultural advisors. And I have to be honest with you, most of the work that I've done is small-scale projects, because in Australia, other than the Law Foundation work, there is very little money for on-the-ground evaluation and research. And so a lot of my work is either done on the smell of an oily rag, or it's done pro bono. And I've often been accused in meetings around the world where I've discussed things like this of, well, you come from a very well-resourced country with great research, and your services are better resourced than ours. And then I have to do the per capita of what you spend in your country and what we spend in ours. And then they're appalled. But my experience is that people who have a mindset of growth and want to change things for their clients can make innovation happen. So that's just a little aside there. So the process that I am looking at is participatory research, involving always checking in at every stage with my Aboriginal advisors and the community that I'm evaluating or working with. Not evaluating the community, but what I mean is I actually check in and say, are my questions okay? I ask them, but I set the questions, are you comfortable with this? Do you feel safe with them? And so that's that. So around the world, colonised communities are still significantly impacted in terms of their life outcomes and ability to advance sustainable development goals, particularly 16.3, which is access to justice, due to impacts of colonisation on various minoritised populations and, of course, discrimination, unconscious bias, etc. This includes ongoing poverty, inequality, poor morbidity rates, and negative health and wellbeing. And including the pulse work that Lynne has just disclosed, this cannot continue to be ignored. So what I'm doing is looking at a study. It's a research and impact evaluation that I've been doing will be doing over 3 to 4 years, hopefully longer, subject to funding. It's due to finish in June, July, right? June, 5 minutes. June, July, that's good. June, July of 2025. So it's a bit worrying at the moment. I'm going back for the next field trip in May. It reports on and examines the effectiveness of the Health Justice Partnership, and this service program aims to improve justice and social determinant of health outcomes for Aboriginal community members experiencing poor mental health and wellbeing. Some theory. I'm using culturally responsive and equitable evaluation and the Indigenous evaluation strategy of the Productivity Commission of Australia and the First Nations Cultural Safety Framework of the Australian Evaluation Society, of which I'm a member. Grounded research and evaluation practice in literature on Indigenous research, and I looked at broader Indigenous research, including that in Canada and America and other countries, but also Aboriginal research in Australia. So it's about the on-the-ground experience of Aboriginal community and includes things like considerations of data sovereignty and the impacts of decolonisation, and also decolonising my methodology. So I'm constantly being challenged and wanting to be challenged about what I think or what the university says, for instance, is ethics approval, and asking them if they feel comfortable with that. So I'm trying to decolonise as I go. So this culturally responsive and equitable evaluations requires evaluation before, during and after to address bias, be transparent, relational, incorporate narratives and co-design and perspectives which acknowledge culture, safety, history, diversity, non-Western perspectives and systemic drivers of inequality. In my view, this is not only a theory, a theoretical framework, it is my philosophy, it is a process, it is an approach, and it recognises the impacts of colonisation, working to ensure integrity, autonomy and self-determination. Now, I'm telling you now, that is not easy to do. There is a dissonance and there is a lot of conflict and you have to resolve it. And my advice to people wanting to do First Nations research is do it alongside them. And if you feel uncomfortable about something, ask them and say what is appropriate, what isn't. And then they'll have more faith in you and more trust in you. So some more theory, just quickly, mindful of time, around investment in people and communities, trust, reciprocity, cultural appropriateness, sustaining activities, capacity building, capability building, fostering local ownership of not only the research, but of the outcomes and the reporting and global thinking. That's my colleague, Linda Gibson, who's a nurse practitioner. So my methodology, which I've been using quite a bit across multiple studies because of a lack of consistency in measurement, I've added a new cohort, what I call benchmark, which is REACH, which was on advice of the Aboriginal community who co-designed this with me and Aboriginal staff at the Health Centre Service. It's REACH. How are we reaching community? Is the organisation reach or the partnership reaching community? Is the government, is policy reaching community? Engagement at all levels, individual, community, organisational, partnership level, and government and policy. Building capability, referring back to Lynne's presentation for that, building empowerment and collaboration. I use the wonderful Michele Leering on my left's philosophy around reflective practice, including involving action research. So as I do the research, I inform the practical delivery of the service, then they can recalibrate and improve. I'm very fortunate to work with great colleagues. So what I want to do, I'm going to skip through the methodological approach because of time, but you can see it's participatory and reflective. I use a range of tools to cross-measure and verify. So what I want to talk about is since the project startup, in 2023, when I did the field trip, I have to say really honestly that the Aboriginal community said they didn't trust justice and they didn't think that a justice service in their health service would be any good for them. Okay. I went back a year later. I took everything they said about what sort of service would make a difference to them and incorporated in my indicators of those benchmarks. I went back a year later and you would not believe the huge jump. They felt respected, they were disclosing, they felt trust. Their professional supports were all saying, or trusted intermediaries, they had been unaware of possible solutions the legal law might offer. And they had increasingly had outcomes around fundamental issues about housing, family cohesion, shelter, income security, safety from violence and other things. The other outcomes of the research were that basically their levels of stress and anxiety had been reduced because of the intervention of trusted lawyers who were approachable, non-judgmental, and worked with them on a continuum. Now, that is something for legal services to realise. And it picks up Lynne's point, that you need to work with on a continuum so that when they're ready and able to do the things they need to for legal resolution, you are there side by side with them, because mental health is paralysing and crippling. And it takes a while. So there's lots more lessons in that, but I'd like to conclude there. Thank you very much, everyone. Next slides, please, for Michele Leering.
Thank you so much, Liz. I look forward to what happens in the next field trip. So as Liz has pointed out, Michele Leering is our next presenter, former executive director and lawyer with the Community Advocacy and Legal Centre in Ontario, and a visiting scholar at Queen's University Faculty of Law, where she, well, in her previous role as ED, helped oversee local justice and health partnership development and promoted scaling up the model through a provincial community of practice. Michele's also researched and written about these partnerships and how they've evolved in Australia and Canada and the US. So a very broad understanding of this field, and also how they've been evaluated. And this included, as I understand it, co-authoring a scoping review about their impact with Queen's University's Department of Family Medicine, which is an interesting dynamic. Michele.
Thank you for that kind introduction. I also want to acknowledge that I come to you from the territory of the Haudenosaunee people, Anishinaabe, in Kingston, Ontario, where I live and work and receive inspiration and now research and write in this new role. And I want to thank the organizers of this conference for bringing us all together, because it's been an amazing opportunity. I'm sure you'll agree. And I also acknowledge the contributions that the prior speakers have made to making my job easier in terms of explaining why the Justice and Health Partnership approach, or health justice approach, is such an important one at this stage in our efforts to narrow justice gaps. So thank you for the contextualization, and I can't wait to see all your slides, and I would like to leave with them, Lynne, so that would be helpful. And partly what I intend to do is to set the stage for speakers who will be speaking about health justice partnership work in Ontario. So that'll be Amy and Jennifer, and to give you just a sense of where we come from, what we're doing, because we're actually on a mission. So health justice partnerships have been underexplored in the Canadian context, although we're starting to make inroads. Today we'll just be talking about the Ontario ones, but if there are folks from other provinces in the room who are doing this work, I hope they're going to speak up or be in touch with us. I also want to contextualize this work within the increased discussions now on an international level about people-centered justice and the Sustainable Development Goal 16.3 on access to justice from the UN. Health justice partnerships have actually been one of the strategies discussed in the reports by the Organization for Economic Cooperation and Development, and even discussed at their recent Global Roundtable in Ottawa 2 weeks ago. There's very much a focus on what law can learn from health And there certainly is a lot, which is one of the reasons why I've loved this work so much after 4 decades of working in the trenches in one of Ontario's community legal clinics, where work with trusted intermediaries is how we do our work. It's more specifically in the last 15 years for sure, but working with people from the social sector and social services sector and churches and other community groups. Moving into the health sector has been a more recent development in about the last 10 or 15 years. And that is because of our shared interest in making the world a better place for everyone, and the concern that comes from the health profession around the social determinants of health and health equity. Developments that started at an international level quite some time ago and were probably predicted by work in Canada in the 1970s that looked at health equity as an important reason why people are actually unhealthy and what to do about it. So this is part of a research project, but I'm going to have a few slides to tell you about. Is part of a research project that had been funded by the Law Foundation of Ontario, looking at how to measure the impact of these partnerships, because folks in the medical profession, healthcare professions are evidence-based. They want to see why interventions make a difference. So it became important for us to think about how we would evaluate and show the impact of these projects. So this wasn't, we did the scoping review. That was an interesting cross-cultural, cross-disciplinary learning exercise. And I can tell people more about that at another time, but it was a huge learning experience for us. We also did concept mapping with our advisory committee, which included an epidemiologist and medical students and law folks and a sociologist, Ab Curry, about how we understand service delivery, what our priorities are, how we measure our work, what we consider to be quality research, which again, huge learning exercise there. We also did a mapping study of what was happening in Ontario in 2019. It needs to be updated, and we actually need a national mapping study now. We were influenced by work done in the UK, which we also looked at, and Health Justice Australia, who were wonderful collaborators. And I think one of my messages here too is the importance of not just cross-disciplinary work with folks in the healthcare profession, but also this cross-jurisdictional work, because we have so much to learn from what's happening in other places. And again, there's a couple of excellent articles that have been written on that can help you on your way to understanding more about this. We also did a small scale evaluation of the Health Justice Partnership work in my own clinic, which did show how important it was for improving rural and remote service delivery. It was the best strategy in my 40 years of practice. And I was hired to do rural and remote work 40 years ago. Early intervention was also something we could show in our little study, and how much it improved healthcare providers' capacity, right? As trusted intermediaries to intervene. So those were all important. Is it 5? Yeah, good. Okay. So whoops, that does it fast, doesn't it? So I think we all understand things this way, but people are at different places in terms of understanding what access to justice is. And I want to just say, operationalizing terms, by the way, is an important research piece, right? We're on quality of research. And for me and for legal clinics in Ontario, this tends to be how we understand what access to justice is. It's a very big idea, and it includes all the public legal education work we've been talking about here, services, legal services, and promoting justice through reform of laws and systemic advocacy, and also making enforcement of laws easy. So it's quite a large definition, and we work in that way. I think we've heard it, a little bit, but we already know that the law is connected to health, and this is some of the social determinants of health information there. And there has been some writing now too on framing access to justice, and law, in fact, is a social determinant of health. I think it's an indicator of the disconnect between the healthcare and legal professions, that we weren't named actually as a social determinant of health 30 years ago. That's something that we need to change. So health justice partnerships, I looked at them in 4 countries, as it was mentioned. So it included the UK, and there's a whole spectrum of different approaches. There have been 8, at least 8 actually. There's probably 2 more now, systematic or scoping reviews that have identified the positive impacts. And very much the change we seek is improved social determinants of health for people, better patient-client health incomes, lower health costs, and greater health equity through access to justice. So this is an excellent study, I think, for summarizing. Sarah Bearden did her PhD on this topic, working with Hazel Gann as her supervisor. People will recognize Hazel's name, I'm sure, from the UK. And these are some of the impacts that they found, very well explained in a lovely short article that cited there. I won't go into all the details because of time, but you can see, like, there are many impacts from this. In fact, I think it's transformative work around our understanding how to improve and reduce justice gaps and improve people's health at the same time. And the common cause we have with people in the healthcare profession. The other systematic reviews looked at the impact for people with cancer, for example, and oh my goodness, I'm forgetting what they all are. Anyways, immigrants and HIV/AIDS populations, but there's been a lot of work done with veterans in the States too. This is just the mapping study we did back in 2019, which I've mentioned already. Really, there has been an existing health justice partnership, not so named since the 1990s. And then Pro Bono Ontario came in with a very interesting project, which is expanded in sick children's hospitals. There is a spectrum of approaches all the way from sort of working with healthcare providers to increase their knowledge of where legal rights intersect with the problems that their clients will have, through to embedded teams. And you're going to hear an example of all those different approaches there. So if you want more information on what was done in this study, there is a huge background paper that also looks at evaluation frameworks, not just looking at health, but also looking at access to justice, outcome factors as a way of thinking about this, and evaluation strategies, or the history and development of these partnerships in 4 countries, because I was concerned as wanting to have a movement in Canada, like how do we advance it? How do we do that? What were the factors that determine things in other countries? So you can already be thinking about how that might be different in the US, for example, where a return on investment and social return on investment was a way that they started these partnerships to begin with. It's gone well beyond that now, but that's where they started from. Okay. Yep. And so this is one of the things we said in the report, that we really do need to build an evidence base around why these partnerships are working. We're going to hear some examples of those today. And that is because we need to have more partnerships, at least across this province, if not across the country. And I think at a macro level, we also need to inform health policy around this. So we've been thinking about that and the role within primary care teams of having legal help available too, or linkages to legal help as part of that. There's, I know I don't have it. I have another slide that I didn't put up there because there were so many, but there are so many things that come from this. There's implications for the training of people in the legal professions. There's implications for partnerships when we don't know what we're doing, for example, around research methodology to evaluate. It's really important that we have those partnerships. There's a need for a discourse change. We need to understand and conceptualize things like legal health and what they mean, and triage and secondary consultations is another one. There's a whole new language that goes with this area of service that we can learn so much from. So thank you for your time, and I'm sure you're going to love hearing from my colleagues about what they're up to on the ground in very practical ways. Thank you.
Thanks so much, Michele. We are now going to pass the baton to Amy. Amy Slotek is a staff lawyer and program lead with Legal Aid Ontario. And since 2016, she has coordinated a health justice partnership with a community mental health agency in downtown Toronto. So we must talk. Focusing on meeting the interconnected legal needs of homeless accused who manage complex mental health and addictions disabilities. So this is very gritty frontline work. Amy is also the co-chair of the Ontario Health and Justice Community of Practice, a province-wide network of academics, legal and health practitioners who promote the health and justice area of practice through access to expertise, support, and tools. Amy, thank you.
Thank you so much, Lynn, and thank you to the organizers. Before I start, I also just wanted to recognize and introduce Tess Sheldon, who is in the front row, and Jada Goldar and Dia Parikh, who are students at the University of Windsor Faculty of Law, and they're completing a practicum at the university's Mental Health Justice Clinic at a forensic hospital here in Toronto. And they have done so much work on this PowerPoint and to contribute to this presentation. So I'd be really remiss if I didn't, introduce them and say thank you. So I'm going to be talking a little bit about mental health justice partnerships as distinct and a separate category really under the rubric of health justice partnerships. And in doing so, I think I want to just contextualize the experiences of individuals living with psychiatric disabilities. Very briefly, I think it's important to recognize the MAD, Pride, and consumer survivor movements that grew out of the 60s and 70s. I just wanted to also recognize, I didn't create this slide, but the gentleman with the hat it was a mentor of mine. So I don't think he knew that when you put these slides together, but he passed away 2 years ago, and he was a survivors' rights advocate in Toronto, and he was advocating right to the end. His name was Don Weitz, and he had a tremendous impact on me and on my practice. So just very coincidentally, Don is in there. Really, the movement grew out of the discrimination, the coercive practices, and the stigma that people with psychiatric disabilities in North America have experienced. And part of that experience is that they've really experienced the medical model as often coercive. And the medical model, when I talk about mental health disability, it's a model that emphasizes diagnosis, containment, and institutional care over personalized, autonomous, and community-based care. And so many service users have experienced the health system actually as a punitive or controlling system. And so when we talk about creating health justice partnerships with individuals living with psychiatric disabilities, I think we can't ignore that history, and that we do have ongoing practices. We have people right now who have, adults who lack decision making over their own finances, who are in a hospital right now, and not able to make decisions about their healthcare and consent at law. So, the challenges in this area are that, we really need to think about different ways of engaging, both as healthcare practitioners, but also as lawyers. And out of this movement, and I'm glossing over a huge history, but out of this movement, the consumer survivor movement, came consumer survivor initiatives. And there's a very interesting history in Ontario around consumer survivor initiatives. They reached a heyday in 1990 when there was actually 40 consumer survivor initiatives running in this province. And I'll just define what a consumer survivor initiative is, because I think it's important to distinguish from medical agencies that employ peers to conduct outreach or to work with individuals. So a consumer survivor initiative is an initiative that is run wholly from the ground up to management by people with lived experience of the forensic and criminal justice system. Everyone that works there has this experience. And today I'm going to talk about 2 consumer survivor justice initiatives that Tess and I both work with. So I'm just going to, just in case you ever want to visit me, the building on the top, my office is to the left. Legal Aid has embarked in a partnership with Sound Time Support Services since 2016. Sound Time Support Services is a consumer survivor initiative. It's 30 years in existence, and Sound Times actually approached Legal Aid. We didn't approach them. And I am the embedded counsel at Sound Time Support Services. I provide mostly criminal defense services, but also ancillary poverty law services that are related to my client's criminalization. The Mental Health and Justice Clinic that Tess is involved in is another example of a partnership with a consumer survivor initiative. The other type of CSIs in Ontario who also reached a heyday are patient councils. And so the Empowerment Council is an advocacy organization within CAMH that advocates for service users who are patients at that hospital. Both CSIs in the community and patient councils have declined over the years. And if you're interested in hearing more about that, you can ask me. But if there are no CICs in your jurisdiction, I challenge you to ask yourself why. because people with disabilities want to live with autonomy. They want to have control over their lives. They want to have control over their healthcare and their legal issues. So if there's none in your own respective jurisdictions, I think there's a question to be asked as to why. And my children always complain that I always answer a question with a question, and I never ever actually give answers. But, some of the lessons I think that we've learned and questions that we really have about embedding legal practices within a healthcare, framework is, what is the difference between being patient-centered and service user-led? What are the barriers to health justice partnerships in mental health settings? And in what ways do neoliberal funding structures impact the effectiveness of mental health and justice partnerships? And all health justice partnerships discuss the role of systemic advocacy in addition to direct legal services. But the real challenge is that measuring systemic advocacy and outreach work is very difficult. So we often, just return to sort of the very easy transactional client-served outcomes type of measurements. But I will tell you, the most meaningful work that I do is actually the community outreach work. The clients that so I could hold discussion groups with clients, and we have lunch together. And the goal is not for me to talk so much, but for individuals to talk. And we've had, city councilors come in. We've had people from the community come in. How to measure that work is absolutely critical, because if we don't do it right, I think then we just stay in the same framework of the transactional direct service approach, which is important. But I think the systemic advocacy is extremely important because, just very basic, I might help somebody stave off an eviction today, but next month they still have to find rent money. And so it feels pretty futile to get them that brief reprieve when the real issue is that they live in poverty and that we have a totally broken system and that people are struggling to survive. And finally, what is the role of law students and lawyers in supporting MAD movements? It's very interesting to practice in a non-legal setting where I've been invited in to provide a service. And I think there's some critical distinctions that are really important for learning. And I'm sure my colleagues would likely have the same thing to say. And I'm under time. I said I would do it. I have a type A personality and I'm very competitive. So thank you so much. I hope you have questions, and I'll pass it over to Lynne.
Magnificently done, Amy. Thank you for that. I'm sure there will be many questions when we get to the Q&A in just a few minutes. But first, let me introduce Jennifer Stone. Jenny Stone is the Exec Director of the Neighbourhood Legal Services and Manager of the Health Justice Program here in Toronto. And previously, immigration lawyer from 2011 to 2018, as I understand it. And this, I think, immigration experience has a great part in Jenny's background. So I look forward very much to her reflections on access to justice through an urban family health team. Thank you. Thank you.
Hi, and thank you for having me. Figure out how to do this. Okay. Hi, thank you so much for being here and for the opportunity to reflect on 10 years of the health justice program. There are so many health justice programs, that is our name. So it has been in place since 2014. This is the 10th year, and we just thought this was a really wonderful privilege and opportunity to kind of reflect on some of the high level takeaways that we've observed in this partnership. Let me first tell you what it is. Effectively, it is a way of doing work. It is, we have an embedded intake paralegal who staffs a weekly drop-in at the family health team connected to St. Michael's Hospital. The family health team is a big urban family health team. They have like 57 or so patients rostered there. Approximately 30% of those live under the low income measure. They have about 80 physicians and 100 other allied healthcare providers and 5 specific physical clinics across the downtown east. The community legal aid clinic that I manage has a geographic catchment area also covering the downtown east, so very much maps on to the catchment area of the St. Michael's Hospital Family Health Team. Within the family health team, there are 28 some odd subspecialties, let's say. So I've heard it said that to be rostered at this family health team is almost like a golden ticket. You know, there are social workers, income security health promoters, chiropodists, dentistry, diabetes educators, obviously nursing, nurse practitioners, just a really rich resource. And for our little legal aid clinic comprised of 5 caseworkers, this is amazing for us. When we get a referral through the family health team at St. Mike's, we know that we can walk back and obviously with the patient at the center of it, consenting, driving the goals, we can put a table together of people from different specialties to brainstorm and work together to help folks solve complex legal problems. And I think what's really happening there is shifting power. So I also would be remiss not to recognize my colleague, Dr. Rami Shukri, who's in the back. Hi, Rami, nice to see you. Rami is the physician clinical champion for the health justice program, did the legal needs assessment when he was a resident at St. Mike's, and is just a real leader in this area and has done tremendous work to push this model forward. So the partnership is effectively between Neighborhood Legal Services and the St. Mike's Family Health Team. We get the funding from Legal Aid Ontario to basically staff the equivalent of 2 people to work on ensuring the relationship is nurtured, developed, and continues to grow. Because like all relationships, it takes some work and it just doesn't happen organically necessarily. In addition to Neighborhood Legal Services and the St. Mike's Family Health Team, we also have 3 advisory partners. So you'll see their logos here. It's Aboriginal Legal Services, Arch Disability Law Center, and the HIV Legal Clinic Ontario. And they all have really interesting and focused and specific areas of expertise that they lend to us through our education initiatives and advocacy initiatives. And effectively, we have them on speed dial. And they take our calls and help us problem solve. So really grateful for their contributions. So the program has a 3-part mandate that direct legal services. We have sort of a smooth process for receiving referrals through the electronic medical record. We don't have access to the chart. We're outside the circle of care as legal professionals, but we have figured out a way to ensure patient privacy, patient sort of autonomy, and we very much respect the different lanes in which we operate, but we can receive referrals easily and then connect to patients to do the legal triaging. A lot of it is system navigation. You know, Legal Aid Ontario is robust and imperfect, and if you walk into any space with a housing, criminal, and family, and maybe income security issue, which is not uncommon, you have to knock on 3 or 4 different doors to access legal services. So that's a big part of what we do, is helping people make connections across the system, sometimes providing the direct legal services ourselves, sometimes getting real creative and just hitting the phones and trying to see if we can get a pro bono practitioner to get on side with a case. The second part of our mandate is interprofessional education. So we're always just trying to figure out how we can learn from each other, break down the silos. This is done through like one-to-one detailing with providers, periodic grand rounds on specific topics of interest, lunch and learns, et cetera. What we have on the screen here is a link to Health Justice Tuesdays. This was this 11-part workshop series that we rolled out in 2019, which we're really excited about. It was co-developed and co-delivered by a legal and healthcare provider, and the intended audience was primary care providers at St. Mike's and in the community broadly. And all of the content is there and recorded. Each presentation left clinicians with a couple of pearls of resources they could take back to their clinic. And we're quite hot off the press, so to speak. Pardon the pun. This is actually being turned into a textbook entitled Health Harming Legal Needs, a practical guide for primary care clinicians in Canada. And we just heard yesterday that it is expected for publication by University of Toronto Press in 2025. So you can look for that, some knowledge sharing. And then the last piece is systemic advocacy. Like as my colleague Amy mentioned, you see issues coming in over and over again, and there's too much of kind of that pulling bodies out of the water emergency room approach to dealing with people at the end of the road and in total crisis. So what we're really trying to do is, walk upstream. We do it through education, by early identification of issues, refer over for some help before they cascade into crises. And also, once we see a trend, let's see how we can maybe marshal our resources to tackle the root cause of the issue that we're seeing. Query and all of this, as already has been mentioned and written about somewhat, that access to justice really is seen as a key social determinant of health, right? Particularly for people who live on the margins. Like, it's not like if you have means, you may have to walk into a lawyer's office to buy a property, to do your will, maybe a family breakdown. Like, you can count on one hand the times that you will probably need to speak to a lawyer in your lifetime, if ever. And if you are living in poverty, like in Ontario, on ODSP is about $1,200 a month. Ontario Works is a little over $700 a month. Now imagine trying to live in the city of Toronto on $700 a month. Everything you bump up against is, to quote Stephen Wexler, a sharp legal object. So like your housing is, you're constantly dealing with legal rules and tribunals, your income, same. If your immigration status is precarious, that is so foundational to every entitlement that you could possibly access. So this is where this idea of like health and justice is all kind of one and the same, particularly if you're living in poverty. So we've got 2 minutes. I'm gonna give 4 high-level takeaways in the remaining 2 minutes of some things that we've observed in our 10 years of the health justice program at St. Mike's. First is that, like the literature coming south of the border, most of the referrals are organized around the key so-called I-HELP factors, right? Income, housing, employment and education, legal status, and personal safety. Many of those issues do map on to the poverty law services that community governed legal clinics like ours do, like neighborhood legal services. If you just walk in off the street, you're going to get eviction, defense, income security, stabilization, immigration law, and some employment law. But coming from the family health team, we get those referrals, but we also get so many more. So really what this has done is exposed gaps in the system. There's lots of stuff. There's a lot of legal needs out there that Legal Aid Ontario does not fund. And that's where we see these gaps really clearly with this kind of urban family health team partnership. Another key takeaway that we think provides just tremendous opportunity is the fact that the family health team is one of 17 teaching sites for University of Toronto's Department of Community and Family Medicine. And so, it's thick with learners, medical residents, but I mentioned those 28 subspecialties. Learners are coming through and gaining practical experience in all of those fields as well. So being able to kind of reach hearts and minds for budding healthcare providers, budding lawyers. We also have students coming from U of T every year for a health justice externship, working alongside learners in these other interdisciplinary fields. We think that's really exciting. And I also want to introduce my colleague, Shafiq Kadri, who is a law student from TMU doing a placement with the health justice program this year. So thank you for being here and welcome. at the beginning, when we started out, and I think I'm going a little bit over, so I maybe have one more minute. We started out small, and site by site, we included new of the 5 family health team clinics. We rolled them out site by site. Until the pandemic, kind of consistently, we were getting a referral a day from the family health team, and it comprised about 16.5% of neighborhood legal services cases that we do. Like I say, you know, neighborhood legal services has been in the community for 50 years. People can walk in, people can call in, people can access us directly, but this sort of special referral stream was somewhat new. During the pandemic, those referrals became 30% of NLS's total numbers, and our overall numbers have not changed. We're just seeing that a greater proportion of them are coming through the St. Mike's Family Health Team. And I think that speaks to the special sauce of relationship development over time. And finally, and I'd be happy to share examples. I've got some case examples organized. I pulled out, sort of went to the last 10 years of annual reports, and I pulled out some key examples of cases that are really complicated, lots of overlapping legal issues and health issues, where we came together as a team and with the patient at the center, got that sort of team around a table and said, okay, how can we tackle this? And that, to me, is where we operate at the top of our game. You know, when we can when we really can collaborate and bring these areas of expertise together. And ultimately, I think it contributes a great deal to wellness of providers as well, because working in a team is way better than, you know, screaming into a canyon on your own at the local legal clinic. And that is my presentation. Sorry to have gone a little bit over. Thank you.
Thank you very much indeed, Jenny. I think the collection of these presentations is building a really interesting picture, and I look forward to the discussion in just a moment. But our final speaker for this session is Patricia Vagg, who has come from Armidale in New South Wales in Australia. And she's a PhD candidate with the Australian Centre for Agriculture and Law at the University of New England, which is based in Armidale. The Ag Law Centre provides innovative scholarship on laws and institutions which affect rural communities to develop policies and strategies that improve rural sustainability and social justice. And that's a really critical centre for this area of exploration in Australia. Patricia, though, is going to present on the area to the west of Armidale. Armidale is quite leafy. Broken Hill is not. And this is a huge area that she's talking about, but I'll hand the mic and let Patricia give you an introduction to the territory that she's covering. And thank you very much indeed for joining us.
Oh, could someone pass me the clicker? Thank you. Hello, everyone. As Lynn said, my name's Patricia Vagg, and I'm a PhD candidate at the University of New England, which is in Armidale, in the Northern Tablelands, New England region of New South Wales. New South Wales is a state in Australia. I live in Dubbo in central New South Wales. And as Lynn said, I'm researching far western New South Wales, researching people's experiences of access to legal services and justice. And in that area, and of all those 3 places I've mentioned, they're all on the land of the world's oldest living culture. And I pay my respects to the elders, past, present, and emerging. And today I'm going to speak about 3 main things. I'm going to talk a little bit about the geographical scope of my project, including a little bit about the people and the lifestyle of the area. I'll speak about the methods I'm using, how the data was collected and how it's being analysed. And lastly, talk a little bit about what the data so far are indicating. I'm still conducting interviews, data's still coming in. So a bit of contextualisation. Here we have on, I think, your left, a picture of Australia in the world. On your top right, New South Wales, which is a state. We have states and territories in Australia. And down the bottom, I have in the paler yellow part to the west. The left is the Western Division of New South Wales. And I'll zoom in on that a bit in the next slide. The New South Wales Western Division, the paler part, is
unsurprisingly, in the western part of the state. It's completely landlocked inland. And many people who live here access their services by travelling hundreds of kilometres to larger towns, either east within New South Wales, within the state, or south to Victoria, west to South Australia, or north to Queensland, or they don't access services. It's a part of New South Wales that's quite diverse in landscape and in people, and it's really wonderful, and it is lacking very basic services. And the reality that services simply aren't prioritised or provided here has been demonstrated as recently as this very week. On Thursday last week, there were seasonal storms and 7 electricity transmission towers were destroyed. And the electricity supply simply stopped. And it has come and gone for pockets of a few hours here and there, but essentially for more than a week, there's been no electricity in this part of the state. For the rural properties that are so remote that they have a unique way of having phone connections, there's also no phone connection. Oh. Stop.
Power here.
Yeah. Oh, it was just getting interesting. Evacuate.
Hi, everybody. This is not a real fire alarm.
Okay.
We're doing a Cadillac Fairview decided to do their fire alarm testing today. We have a floor exemption. You do not have to walk 26 floors.
I won't go through the whole thing again, but just to explain a little bit about that, I'm studying in Armidale, but I live some hundreds of kilometres west of there in Dubbo, and I'm researching an area many hundreds of kilometres west of there in the west of the state. And I provided some maps to contextualise that in the world and in Australia. And I was just explaining a little bit about the lack of services generally, not just legal services, and that's been really exquisitely illustrated in real time this week. There were some seasonal storms last Thursday, and they knocked out 7 electricity transmission towers. So much, not quite all of the pale yellow area, but much of the western part of that area, hundreds of thousands of square kilometres, has not had electricity for over a week, and many of the people on the rural properties out of town have also not had phone service. And yeah, it's just not something that would happen or be tolerated or be politically palatable in other places, and it wouldn't be able to continue if it had even happened in the first place. So I'll move on now to a bit of context about the Western Division. Sorry, that's very touchy. It's a really beautiful place, unique lifestyle. There is one city, Broken Hill, which Lynne mentioned, has about 17,000 people living there. And everyone else lives in towns of a few thousand people or a few hundred people, like in the top left slide, or on rural properties in the bottom right slide. In the past, properties nearly exclusively ran livestock, and now there is some cropping, there's some mines, there is some unemployment, and it's a place of extremes. There's a small number of people, very large travel distances, quite cold in winter, frosts, quite hot in summer, 50°C days. In fact, during this more than a week of no electricity, there have been 36-degree days, that's about 97 degrees Fahrenheit. And quite low rainfall, large numbers of livestock. There's just quite a lot of diversity and extremes. The size of the area, the yellow area on the previous map, is about 325,000 square kilometres. So that's about the size, a little bit smaller than Germany or Malaysia in land area. And for the 50,000 people who live across this space, there are fewer than 20 practicing lawyers. But the people who live here have the same legal needs as people in any other place in Australia and in the world. And clearly people everywhere benefit from legal information, legal advice, legal help, So it would be good to find out more about what's the best way to provide it here in these places. Where and how do people want to and need to access their legal help? And what's needed here in the Western Division of New South Wales might not be the same as what's in cities, but importantly, it might not even be the same as what is needed and is useful in regional but far less remote places. There's what for many years has been talked about as RRR, regional, rural, remote, is now in Australia at least, and perhaps in other jurisdictions, being called 4Rs, regional, rural, remote, and very remote. And of course, there are different measures and definitions, but in just about any of them, this is very remote. So to find out more about what people need, I'm listening to people talk about their experiences, and I'm doing that through semi-structured conversational interviews, and there are two groups broadly of interviewees. There are the people who live here in Western New South Wales, and there are the people who design legal services or provide legal services for the people who live here. This is lawyers, members of the judiciary, judges, magistrates, financial counsellors, policy officers, people who design as well as provide legal services. So I'm listening to the experiences of users and of providers, and those two categories of people will talk about their experiences so that I can hear what works, what doesn't work, what might work. And I'm analysing these data within a framework of access which looks at both those perspectives, providers and users. It's a conceptualisation of access, and it's perhaps a bit small on the slide, but I've popped one sort of summary encapsulation of it up there. It's a conceptualisation of access to services that's very well recognised and used in health, and I'm bringing it across to law to analyse access to legal services. You might see down the bottom of the slide, I've provided the name of the author of this conceptualisation, and I'm Australian and I've only ever heard Australians pronounce it. So if anyone would like to shout out the correct name, so to save me embarrassment. Oh, well, that's what I would say, Levesque. Thank you. So this slide shows that accessing services doesn't happen in a vacuum, as we all know. It's within structures and organisations and systems, and that the people who need services, legal services and other services, have their own unique personal attributes, circumstances, and that's shown in this model. Across the top are the things that providers of legal services should perhaps think about so that they can provide services that are relevant, that are good, and that provide justice. And across the bottom of the slide, some of the things that can be having an impact on people when they need legal help and when they're hopefully seeking legal help. Things like time, transport, literacy, whether that's functional literacy or legal literacy, cultural norms. So I'm still conducting interviews, as I mentioned earlier, it's not finished, but I've analysed the interviews so far within Levesque's conceptualisation of access, and I'll briefly present some preliminary data. I'm just doing them just for this presentation under the top layer of headings, the provider perspective. But it is obviously informed by the bottom layer, the needs of users and the impact on users. And you'll see when you read them or when I talk about them, some of them are presented as challenges with solutions not yet provided or suggested, and some are, perhaps solutions or suggestions of how things could be better. I'm only presenting one illustrative theme under each heading. There are many more in the final write-up. So firstly, approachability. Something that has come out in the interviews might seem very obvious is that if service providers, including ones that aren't even related to each other, whether because they're different jurisdictions, state or federal, or because they're different not-for-profits, if they could communicate and plan together so that when they provide mobile outreach services in these very small towns, maybe they could do it on the same day in the same place so that people could make a single journey into town to meet several of their needs. That's just something that doesn't happen. And either people are telling us they fall in the gaps, they don't access the different services on different days, or they attempt to, but it comes at a great opportunity cost, travel and other costs. We also have acceptability. I mentioned there aren't many lawyers out here, maybe 20 or fewer practicing lawyers in this 325,000 square kilometres for about 50,000 people. And so quite often practitioners are conflicted out of a matter. They can't act. And this isn't a new concept. Many of us would be familiar with this, but here is data about it. And you'll see that this one at this stage is a challenge. We haven't really got a solution suggested yet, but there's more data being analysed. The third one across the top from the provider perspective is availability and accommodation. So one theme I have selected to illustrate this is that the population's so small and the distances so large that often there aren't enough people. There's a certain catchment area that the legislation allows a jury to be impanelled for some matters where a jury is either required or allowed by choice of the defendant. And the result is, because there simply aren't enough people living there, or because they're excluded because they know or are related to people in the trial, people can't have a jury trial. And it's a significant issue because the legislation clearly states that for some offences, they're entitled to a jury trial. It's a massive impact on the rule of law. And at this stage, that's another one I'm presenting as an issue, a challenge without really a solution yet. Affordability is the fourth one across the top. And this isn't just the cost of legal advice or legal representation itself, although that can be costly. It can be the opportunity costs, travel distances, time, the cost of accommodation in town if you do and are able to travel. There's very little public transport. It's often people can get lifts with family members. But also for people who live on farms or rural properties, the cost, or in fact the literal impossibility of being able to leave to access legal help during times like shearing or harvest. The fifth one that I'll provide one illustration of is appropriateness. Residents are telling us, unsurprisingly again, they need credibility and trust in a practitioner, someone who can communicate in an understandable way, who understands the lifestyle and the people and the values. Also really vital is an understanding that there are people who will not go off country to access legal services. Also, First Nations people frequently or consistently won't go off country to access health services. But no matter their circumstances, people should be able to get legal help. This is a public road maintained by the government in the Western Division of New South Wales. And this is illustrative of levels of some types of services provided that after quite a small amount of rain, it is simply impassable. People on neither side can move forward. They're stuck. And maybe there's a metaphor in there about people trying to drive along it too, and then they damage it, so the next person can't get through. And maybe a metaphor about all that unrealised potential in the distance, but there's a barrier right there. Too many metaphors? I'll start with the alliteration next. But really, everyone, no matter where they live, should be able to access legal services and should be able to access justice. So thank you, everyone, for your time and for accommodating the fire alarm.
Well done, Patricia. That was a sterling performance against the odds. And I think your metaphor of getting through the impassable road applies to you as well. Thank you to you all too for your patience in sticking around. And as I mentioned earlier, if you've come into this session on the strength of the next one, you're getting bonus Q&A on access to justice and health. We have negotiated a very brief window for questions from our beloved Dean, Trevor. So if you have a question for us or for any of the panel members, if you would like to offer it now. Naomi, good morning.
Hi, thank you very much. That was a wonderful panel. My name's Naomi Kreutzfeldt. I'm an academic from the UK. I just wanted to mention something, and it's a question maybe to all of you, which is about funding. I think only one of you mentioned where funding comes from. So part of why, in my opinion, that the UK has not been that successful with co-location or partnerships is because there might not be an explicit political appetite for it, but also those that do exist, the funding ceases. That's why you can't evaluate them. That's why you can't show what effect they have. So I just wondered if there's secure funding or if it's an issue for the organizations that you work in. Thank you.
I can comment first on the one that was at our legal clinic. It was sort of transformation funding, but then we could embed it going forward because we're a community-based clinic, so we could do it. So it didn't have ongoing funding, which does challenge things for sure. But it's also an issue of embedding in existing services and streamlining better. But my other colleagues will speak to how they've got funding.
Jenny and Amy.
Sure. So my program is started out as a pilot. It's been 8 years, but it is a program. So Legal Aid has adopted this as a strategy, in particular because the clients that I serve are homeless, and there's really such a lack of access for those clients. I mean, I will just, I'll get a little political, and like in the case of community mental health, there's so much evidence that embedding healthcare services in peer support spaces reduces ER visits. It's promotes political and social connectedness amongst people who are extremely socially isolated. I think there's a lot of data that also, speaks to the value of having legal services embedded in spaces where politics happen. I don't think that the people that power these decisions see the value in that. And I'll leave it to you to think about why that might be. I see some nods, so I think maybe we have some similar thoughts.
Yeah, thanks for the question. It's a great one. Similarly, ours was the Health Justice Program with St. Mike's was funded through some transformation funding. It was a pilot for a period of time, and then in 2019 it became permanent, and it's now part of our permanent funding. So the legal clinic that I work at, we have 10 staff total. We get about 1.2 million a year is our budget, and 200,000 of that is now earmarked specifically to provide this service at St. Mike's. So that's permanent funding, which is great. It's equivalent of about two staff people. But I think part of the politics, I'm going to go there too, in this province at this time is that legal aid is frankly, I think, seen in the corridors of decision makers as, why are we paying for, like, why does provincial money go to defend criminals? What? Like legal aid is seen as defending the bad guys. And I think what we really need to do is disabuse decision makers of that myth, because really legal aid is about stabilizing people's housing, keeping them from being evicted into homelessness, and stabilizing income, stabilizing immigration status, all that stuff that actually just creates like stronger and healthier societies. So, there's some chatter on this panel about some excitement, because to date, apart from a lot of really generous institutional support from hospitals like, say, Sick Kids and St. Mike's or Unity Health, lots of, protected time for clinicians to, engage in this work. Otherwise, like the real funding has come from legal aid. So we do have to give kudos there in terms of just paying for salaries for staff to, that make the work happen. But there's politics, right? Like there's a moment, it's probably going to be an election. Everybody is complaining about the fact that, thanks, we have beer in the corner stores, but help me get a family doctor. And so, Jane Philpott has been tasked by this provincial government to institute some sort of action plan for primary care. And she's recently written a book, sort of a manifesto about her vision, and it does include embedded legal services, tax clinics, this idea that everybody should have a family doctor, a primary care site, just like every kid has access to a primary school.
or free public school. So sort of importing that model in, and we're here for it. I think
Well,
I can
that's
speak
why
for.
we're doing it, but I think the health equity and social determinants of health is the way in. And it's one of the reasons why this is one of the most transformative projects, because we're actually talking about health and better lives for people, and the good life, as we heard the other day, right? So that's, to me, why the cross-disciplinary work has been so exciting.
Can I just add something for a UK context, because I work in the UK, and I'm working with the access to justice and funding scenario there. When the precursor to the BBM project is a now 12-year project for young people. It started as a 6-month pilot. TIP, really good embedded evaluation that demonstrates what works, why it works, how it works, what needs to change, and recalibration services that demonstrate effectiveness, efficiency, and importantly, downstream savings to other departmental issues. In the UK, we need to build that. I'm happy to work with people. We are building that, and there are different scattered because of the funding landscape in the UK, which is appalling. But what we're trying to argue with the new Labor government is it's about applying misused, poorly allocated services elsewhere, not new money. So let's talk. Okay.
I think we have time for one more question. Elaine.
Hi, thanks so much for your presentations. They were so good. I guess this is for all of you, but I guess especially Liz. Oh, yeah, sorry, Liz. I guess I just had a question about, I think one of the well-documented challenges with joined up services is the challenges of working with legal practitioners that I guess some social workers and health practitioners have noted. And I was just wondering, I guess, what your thoughts are on what makes an effective legal practitioner in that kind of setting, and whether you have any ideas for what kind of cultural structural change needs to be done in kind of legal education. I know that's a big question. So,
and can I also, yes, we've been told to wind up ASAP.
I'm going to be very quick, but what I'm again happy to take the conversation offline. But excellent question. It's not easy. I said it in my presentation. Respect, humility, approachability, actually listening to active listening to people. Lawyers like to talk. Actually having respect for other professions. Lawyers tend to think they're experts and that the legal problems are more important than anything. So humility is key, reciprocity is key, and importantly, underscored, secondary consultations done well build trust and relationship. I've got a body of work now over, I think, 20 years that supports that. So happy to talk. Yeah.
We will have to leave it there, but thank you so much to our panel. Amy, Jenny, Patricia, Michele, and Liz. And thanks so much for your attendance too. We'll wrap it up very quickly and make way for the next session.